How many times have you encountered a small ulceration of the lip, tongue, or oral mucosa during a clinical examination and assumed that it was traumatic in origin, an aphthous ulcer, or simply a lesion likely to resolve spontaneously? Yet the painless ulcer we are examining may, in fact, represent the first clinical manifestation of syphilis. This is one of the topics addressed in the book Sexually Transmissible Oral Diseases, edited by Dr. Prabhu and colleagues. Syphilis is characterized by an exceptionally diverse spectrum of clinical manifestations, and its ability to mimic numerous other diseases makes it a significant diagnostic challenge, including for dental practitioners. Syphilis is caused by Treponema pallidum, and transmission most commonly occurs through direct contact with an infectious lesion. Of particular relevance to dentists is the fact that the portal of entry is not necessarily confined to the genital region. The oral mucosa may also serve as a site of inoculation, while minor mucosal abrasions may further facilitate transmission. The authors note that such mucosal disruption may occur during oral sexual contact, but may also result from biting, sharp components of dental prosthesis, or fractured teeth. The initial manifestation of primary syphilis is the chancre, which develops at the site of Treponema pallidum inoculation. This is where the diagnostic challenge begins. A syphilitic chancre is typically round, indurated, and painless. When located within the oral cavity, the patient may not even consider that the lesion could be associated with a sexually transmitted infection. More importantly, the lesion may regress spontaneously even in the absence of treatment. Resolution of the ulcer, however, does not indicate eradication of the infection. This may create a false sense of reassurance. The patient notices an ulcer, it disappears after a period of time, and the entire episode is subsequently forgotten. Nevertheless, following local multiplication, Treponema pallidum may disseminate through the lymphatic and hematogenous routes, allowing the disease to continue its progression. Primary syphilis may subsequently be followed by secondary syphilis, which presents with an entirely different spectrum of clinical manifestations. Of particular interest to dental practitioners is the fact that oral syphilis may closely resemble other pathological conditions. A primary oral chancre may present as an indurated ulcer with raised margins, and may clinically mimic an ulcerated squamous cell carcinoma. The differential diagnosis may also include major aphthous ulceration, tuberculosis, and deep fungal infections. Thus, a single oral ulcer may generate a differential diagnosis ranging from a relatively benign process to malignancy or a serious systemic infection. The diagnostic picture becomes even more complex during the secondary stage. Oral manifestations may then be highly polymorphic, with mucus patches representing one of the more characteristic findings. Their clinical appearance may resemble chronic hyperplastic candidiasis, leukoplakia, oral hairy leukoplakia, or the plaque form of oral lichen planus. Because of this considerable variability in clinical presentation, syphilis may readily lead the clinician in the wrong diagnostic direction if assessment is based solely on lesion morphology. Another particularly noteworthy point is that oral and pharyngeal manifestations may occur in approximately one-third of patients with secondary syphilis. The disease may subsequently enter a latent stage, during which the patient exhibits no apparent clinical signs or symptoms of infection. For this reason, dentists should not attempt to diagnose syphilis by visual inspection. That is not the message of this discussion. Rather, an unexplained, painless, indurated oral ulceration, particularly when the clinical presentation or medical history is inconsistent with common traumatic or aphthous lesions, warrants careful and systematic differential diagnosis. A definitive diagnosis should not be established on the basis of clinical appearance alone, but through appropriate diagnostic investigations. The authors emphasize the importance of serological confirmation of the disease. Perhaps the most important lesson for everyday dental practice is therefore this: sometimes an oral ulcer is not merely an oral ulcer. It may represent the first visible manifestation of a systemic infection that will continue to progress even after the lesion itself has disappeared.